And without further ado, it is my honor and privilege to introduce Dr. Kristen Rising, who is the director of the Center for Connected Care and a professor of emergency medicine at Thomas Jefferson University. Thank you, Dr. Rising.
Thanks, Rob. It's a pleasure to be here. We actually just found out we had been neighbors within a block of each other for years in Philadelphia and just met here. So, you know, small world. So a pleasure to be here today to talk to you about the work that I and my team have been doing on equity through the lens of kind of the term I've taken on and which I'll talk to you today about of digital health readiness. Conflicts here, I have a whole bunch of research going on, lots of federally funded work, and then some industry-funded trials as well. So Abbott and Siemens here. I wanted to take a moment before we dive into digital health readiness just to give an introduction to the research center that I run. So I am a professor of emergency medicine at Jefferson in Philadelphia. I do still work clinically a small part of my life, but I spend most of my time running a research center. And globally, our kind of broad portfolio is really united by our focus on developing and testing patient-centered approaches to bridging gaps across the health and social systems. So we're very much sitting at that interplay, and I talk about the system a lot with my team, and that system is always health and social together, because I think it's really impossible to tease them apart when you're talking about any one individual's life. And we've got really a broad range of portfolios. Here are some of the primary ones. We have a lot of work going on looking at food as medicine and gathering more rigorous data to get insurance coverage for that. We work on vaccine confidence. We've got a lot of work in harm reduction with people who use drugs. And then kind of the focus is more relevant to this group is looking at telehealth models of care to expand access to otherwise limited services, things like palliative care. And then really a very primary focus that's come about since the onset of the pandemic, focused on digital health equity, which is what we'll focus on here today. So my objectives for today, we will spend just a moment on the first, because we all in this room know about this, but looking at the rise of telehealth with COVID, and along with that then an introduction to this term that we've taken on, the term of digital health readiness, and think about what that is, and then how thinking about this in the context of digital health readiness can really help us to have a concrete path forward in the space of digital health equity. So I started at Jefferson in 2014. At that time, I was recruited there with a group of other individuals by the then president of Jefferson to start a telehealth program at Jefferson. He really said in our group interview, "I'm convinced someday we're going to need it, and I want to be ready when we do." You know, who knew it was a pandemic he was referencing? But in 2015, we launched Jeff Connect, which has been growing and has a range of services kind of since that time. But this wheel is kind of how we think about development of the services, and I think a helpful place just to kind of think about with telehealth programs, that we really thought about this from the patient experience and like what it is being a patient, right? And so at any point in time, you're sitting somewhere on the continuum of health. And that bottom part at 6 o'clock is baseline health, right? And then you might get a little sick, moderately sick, emergently sick, into acute care, to the post-acute care time, and then back to baseline or at a new baseline, right? You're not kind of like just back to health, you're at whatever your baseline is. And this is kind of the context that we've looked at and developed out our services. So I'm a founding member, physician member of Jeff Connect, and I've been at Jefferson since the beginning to be kind of the academic lens to telehealth, to think about and kind of elicit what patients' needs and desires were related to telehealth to help with designing our programs. And really until the pandemic, it was that focus of telehealth was a nice thing that we offered to people who wanted it. It was just a nice other option. But then suddenly the pandemic came about, right? And patients were avoiding needed health care, and providers were triaging treatments by urgency, and suddenly telehealth became a necessity to get care. And we were ready at Jefferson to do that. We'd been doing it for years, but only some of the patients really were ready. We did see this, right? And this is the kind of rise of telehealth and COVID. So this is what we saw at Jefferson. From 2015 to 2019, on average, we'd been doing 10 to 15 on-demand visits a day. Now, when we talk about on-demand, that's an emergency medicine physician who staffs a kind of virtual urgent care line that anyone can call for a video visit and discuss whatever problem, 24/7. So we had 10 to 15 of those visits a day in our system. We had 40 to 60 scheduled visits, and we had done 100,000 total visits over that time period from 2015 to 2019. In March 2020, literally overnight, on demand surged to over 200 visits a day. We had 2,500 to 3,000 scheduled visits, and we had 100,000 visits in that first month. This is just a day by day to depict it again as we all lived it, but this is in March, if you can see those middle ones, right? March 16th, 17th, 18th, and just the kind of switch that we had from office visits to telemedicine visits was really immense. And so the whole focus of us here, right, is thinking about the equity piece. And so there were a lot of important things, right? What was the quality of the visits, kind of every other part of it, but the equitable getting patients onto the visit was really a primary part that I and kind of our team at large really started to focus on. And so as I've had discussions with people over time, I've looked in literature, kind of, looked at what people are talking about with this digital divide when we start to think about the concerns of kind of people not accessing telehealth. These are the traditional things that mostly are discussed, right? Do people have access, and that's access to a device? Do they have access to internet and kind of sufficient internet? And then do they have the knowledge to use that device to kind of engage in, online platforms, right? That digital literacy part. But that's really as far as most of the discussions go. These things are important, so we'll look at that in a minute, right? There are some issues around access and knowledge. So for example, one survey that we did in 2020 at Jefferson in the Cancer Center, we surveyed patients and caregivers to look at these access issues, right? Do they have access and access to the internet, and do they use it to get health information? Do they have a smartphone? Do they use mobile apps and other wearables? And so this is what we found. We had 363 participants, close to a quarter of them were over 70, equal kind of mix of genders close to. And, we did find disparities in some of the things that people would talk about, right? So people who were older, so people over 70, were less likely to own a smartphone, less likely to routinely access the internet, less likely to find and download an app unassisted. Also, people with lower education, less likely to have the access and the use. And then finally, people who reported non-white races were also less likely to have this access and use. And so that digital divide, the knowledge and the access is a thing, and we see that there are certain groups who have lower access and knowledge, right? And so I'm going to skip over that. We'll go back to in a minute. So it was a profound time for me in 2020 when I was involved in and led this project from kind of the Federal Communications Commission to realize how much more we needed to do and how much it wasn't just access and knowledge. And so early 2020, when kind of the funding call came out from the Federal Communications Commission, from the CARES Act, for institutions to apply for funding to address the access gap for patients, I applied on behalf of Jefferson. We got $922,000 to get iPads and remote patient monitoring to devices, and we distributed devices to 855 patients, and some got many devices. Along with that, I looked at that first and said, we're just addressing access. We've got nothing for even the knowledge piece. So I also put together what I call the Digital Onboarding Task Force. This was a task force of about 30 Masters of Public Health students who were doing proactive outreach to all of these patients to figure out, do you need help with how to use the devices? Do you need help setting up your patient portal? How can we help you? Spend hours with some of the patients, getting them everything from making an email address and kind of really kind of getting to the point of use. And even with all of that effort, when we looked at use probably a year later, it was good that 72% had an active MyChart account, but still over a quarter of our patients didn't have an active patient portal, which meant remote patient monitoring devices certainly couldn't be transmitting, and more just kind of basic other telehealth needs, engaging in their telehealth visits, checking their labs, communicating with their providers, wasn't happening. Just over half of them had had at least one telehealth visit with a provider. And only 32% of those who had remote patient monitoring devices were successfully transmitting reads. Now, they may have still been using those devices for important information, collecting their blood pressure, collecting their weight, and communicating those to their provider, but that kind of remote tele piece was really missing. And so that brought us to a couple important concepts, right? So telehealth as we've all been discussing here, can help decrease healthcare disparities, but only if we address the digital divide. And importantly, addressing access and knowledge is far from enough. And so that's been what we've been focusing on since, and coming up with kind of the term and the approach for how we think about and really kind of identify the underlying core issues. And so part of this really came from suspicion of some other stuff there. You might ask why we asked specifically about this, but my colleagues and I did a survey of 162 patients who had been involved in some of our other research at Jefferson, in that first year of COVID, to ask them about some of this other stuff. So we asked them if they'd ever had a prior telehealth visit, if they had access, right, do they have the device and the internet use? And then we asked them about some issues around trust. How much did they trust the use of telehealth? How much do they trust physicians' ability specifically to diagnose COVID? Because that was a lot of still what was most visits were for at that time. And we found among these patients, so we had 157 participants who participated in the survey. Access and use was actually pretty high, right? 93% had smartphones, 92% had internet, and 87% of them could do video calls. That said, only 39% of them had a prior telehealth visit. And so there was a great divide in that area. And when we compared the group that did telehealth visits and the group that didn't do telehealth visits, we did find that the group that didn't had significantly lower trust in a doctor's ability to diagnose COVID, and lower trust in the doctor's ability overall to treat at all via video visits. Back to that talk this morning, area deprivation index, right? We also found that higher area deprivation index was associated with a lower likelihood of using telehealth. There were no differences in this group in telehealth, actually, remarkably, by age, sex, education, literacy, their hemoglobin A1C, their knowledge of COVID. None of that really affected who was using in this group. That trust was the primary thing. And so that takes us now, right? So addressing access and knowledge isn't enough, and added in that, like, very firmly, trust is an important underlying barrier to digital health use. Good to know. Really hard to address though, right? Like, that trust piece is one of the biggest things we struggle with in healthcare. And so digital health readiness, this is kind of laying out the term and where we've been thinking. So access to knowledge is important, and that's been that kind of traditional digital literacy, and that's what most people talk about in the digital divide. I want to add in these other things and kind of expand that concept. So thinking about trust, we know is an issue. Acceptability kind of falls in there. Is it acceptable to get care via telehealth is intimately linked to the trust, and it's something we've been hearing from people. Relevance has come up as another really important one, right? People saying, I've gotten healthcare in person my whole life. Like, why would I bother? Why do this? It's just different, and I don't understand why. And so, and then some other things, right? We're still working on what the other things are, but this is what we've taken up to really think about in that broader context, and digital health readiness is the term that we all use now. And so I'm going to talk now about some projects that we've got going on in the center related to this work. I'm also happy we have plenty of time here. I'm not going to take the full hour. If there are questions and people want to talk about things as they go, you can raise your hand. I'm happy to interject or just have discussion at the end. But so the first thing we'll talk about is this past September, my team hosted a national consensus conference funded by the Patient-Centered Outcomes Research Institute that was focused on developing a patient-centered research agenda to reduce disparities in telehealth uptake. We'll talk a little bit about that process and give you some findings from that. Still a lot of dissemination next steps to do from that work. Then I'll talk to you about the work that my team's doing to actually develop a digital health readiness screener. Can we name these specific elements that go into digital health readiness and then find a way to actually start to screen populations and address their unique barriers? And then we'll talk about a few community initiatives that we have going on, kind of applying this work in our community in Philly. So for the consensus conference, as I said, our goal was to develop a prioritized patient-centered research agenda to reduce disparities in telehealth uptake. Ultimately, the hope with this agenda would be that it can help guide researchers what questions to ask next in the studies they're developing. And very importantly, because we have to write the funding applications to the funders asking for it to really guide funders to what work they should fund next. This all was done in really close collaboration with patient and community partners. We had, I'll, on the next slide, show who they were, but we worked with a local, what we called the TAB, a Telehealth Advisory Board. And so this is a group of individuals who are patient and community members in the greater Philly area, who worked with us throughout the year in planning for the conference to think about how we could both develop the conference to be meaningful to patients and community, but then also how we could make the conference something that was something they could participate in, that felt like something that was appropriate for patients to be sitting there and having dialogue in, and not just another academic conference. And then we worked with a national steering committee to think about some of the same things, what was included in the conference, also kind of to think now about what dissemination pieces we may have from that. And as mentioned, the funding was from PCORI. So here's our Telehealth Advisory Board of local members you can see listed here, and then our steering committee, notably which Kathy was on as well. It's been a pleasure to actually meet her in person for the first time, but we've engaged a lot over this and other projects in the past. And so for the first step of this consensus conference, if anyone's not engaged in like a scoping or a scoping review process, I highly warn you to like know what you're walking into before you do, because this was quite a process. And so it was a scoping review trying to figure out all of the literature that exists in this area to help guide the discussion we had at the conference. What do we already think we know to then go for what do we need to know next? And these are the research questions that the review was designed off of. So the first one, and these are broad, which is part of why it was such a kind of beast to do, but what are the barriers and disparities to telehealth use and uptake documented in literature? And then also, what may lead to barriers and disparities in telehealth use and uptake? So we had extensive search terms designed to pull out all the articles from this internationally of what existed up to the time of our review in 2021. This was what we had. So we had over 11,000 articles to screen through in the beginning of things that were potentially relevant. And we got down to a total of 620 articles, which seemed kind of focused somewhere within the area of what we were looking at. So still a lot of studies in the end of the day. Some observations we had overall from that, and some important things for us to think about kind of when we have dialogue and are defining things moving forward. First of all, the focus on telehealth certainly has surged. That was no surprise. We were including things from the first years of COVID. There were drastically varying definitions of telehealth. I think all of us in that room have probably been in discussions about that. What do people mean by telehealth? And actually, we intentionally mean different things, different places. Is it audio, video? Is it just video? Is it with remote patient monitoring? But it's not always well defined in things either. And so when we're having conversations, we need to always be explicit about what we're talking about. And then there was a real lack of standardization and validation in measurement. Study populations, so people talk about older patients and younger patients, but older, so, you know, the cutoffs were 60, 65, 70, 80. And so defining study populations was really hard to then compare and understand what we were talking about in terms of comparing them. People in groups for comparison also, it was just, the ways people looked at it and cut it were always so different that, again, being able to pull together the data and have some comprehensive understanding is really limited. And then outcomes in terms of what people were thinking about when you're looking at barriers to telehealth or thinking about what is a successful outcome. There was no standardization and not much kind of thought around what meaningful outcomes really should be. Also in these articles, we found overall just general limited depth of findings. Lots of work to do in the academic land still here. So then we took, and we'll go through some of our findings then, but we basically collated everything from the scoping review, and then we had this national conference. So this conference was in September of 2022. It was a consensus conference. For those of you who haven't been involved, that's a specific type of conference where we're very kind of purposefully select people and invite people to represent a really diverse group of stakeholders. So we had academics there, we had clinicians, we had community members. We worked to get as many patients as we could from around the US. We ultimately had 62 participants. This was done all virtually. And we went from drafting an initial set of 58 research questions to prioritizing the top 20. And then we have voting results from that for just the patient group as well as all attendees, which led to some really interesting comparisons ultimately. So this is what we looked at and kind of what we talked on the conference in brief. So when we looked at we decided to focus on just the US studies, right? We had those 605 studies, 334 was still more than enough, and we were all US stakeholders at the table. And so we focused on 334 studies. 71% of them had quantitative methods, so the majority of them involved at least quantitative methods. 3/4 of them involved synchronous telehealth. Some might have also talked about asynchronous, but the majority had discussions around synchronous. Over half were conducted during COVID. You can see that on the side. The number of studies in the years they came out, 2020 and 2021, certainly had by far the most. 58% of them had data specifically looking at barriers, and 47% had data on disparities. And I'll show you those just in brief. So when we looked at the barriers, these are some of the main ones that came out. So this helps to start to build out that digital health readiness list. What are those things, right? So these were 194 studies and kind of many of the buckets that emerged. Again, this is at still a pretty high level, and we have a lot of work to do to get more granular yet with all this data. So inability to use, so that's to the knowledge. We knew that one, right? Lack of access. These are ones we've talked about. Concerns about lack of quality or adequacy of care. I would still, in my mind, bucket that in that larger kind of trust part. I don't trust that it's quality care, but this is specifically on the quality. Lack of trust without kind of greater definition came up. A lack of interest or relevance, right? That goes back, and that's our job of the healthcare system to show people why in almost everybody's life, sometimes it's relevant to do telehealth, right? Lack of cultural competency. Challenges with the patient environment, right? So we asked even, right, do you have access to internet? The questions need to be things though like, do you have access to internet in a place that's private enough you can talk about your healthcare? So the environment is very important to be thinking about. Cost of services for some was a concern, and overall just lack of awareness, and prior negative experiences. And that's certainly gonna feed it, right? The patient experience is like fundamentally relies on the fact that we as providers believe in and are savvy in the telehealth in the beginning to give them a good experience. So in this consensus conference, we presented these findings, this kind of initial table to people, and then we had a range of breakout groups. And in these breakout groups, all of our participants talked in depth about the findings we'd had thus far, their own experiences, and then developed lists of research questions. These are some examples of the research questions that came in that first round and that fed those 58%, right? So what are the most effective ways to identify barriers to telehealth use, right? We don't have a good way to do that right now. Does addressing barriers to use actually lead to increased use and importantly to improvement in patient-reported outcomes, right? Like if we then give you the device or talk to you to increase trust, are you actually gonna use, and that's gonna help? And then what interventions are most effective at reducing each of the identified barriers, right? We talked a lot also about, you see this, are interventions effective for specific populations, right? There's probably not a one-size-fits-all approach. And then disparities, we had a similar process. We talked about barriers, we had all these discussions, we came up with drafts of research questions, then we talked about the disparities. And these are some of the things that came out in the scoping review. If you see a plus sign next to the group name, that means that population was statistically significantly more likely to use telehealth. If you see the minus sign, that they were less likely. But we see it's many of the things or all the groups that people have talked about at some point, right? So insurance status affects use of telehealth, and race is associated with, I don't want to say race effects, but race is associated with differential use in telehealth. Age as well, ethnicity, English proficiency, literacy, socioeconomic status, education, chronic conditions. They are all the things that people talk about, right? And it does come out in the literature. These were some of the research questions we came up with, though, for thinking about next steps. So what are appropriate metrics or outcomes for assessing success in telehealth interventions other than telehealth use or non-use, right? That's an important one, and does it vary by population? How do we systematically assess and address the unique telehealth-related needs of each individual instead of relying on common group categories, right? People had a lot of struggles that to date we talk about how Black patients use telehealth less. Well, we shouldn't be separating by the Black patients. That's not the reason they use telehealth less, but like, how do we talk at individual levels and look at this in any sort of systematic way? Very hard to do, right? And so ultimately, we came out with a bunch of themes. I put these here just for kind of thinking around, and then I'll show you our top 3 rated questions from both the groups. So the themes of things that were important in barriers and facilitators was thinking about patient-important perspective, cultural issues, trust-related issues, linguistic issues, specifically technology for the disabled. For outcomes, again, patient-important outcomes, and just instead of just what health systems say. Impact of interventions to facilitate telehealth on ultimate patient outcomes, right? A lot of people have trouble with the fact that we say, does doing this increase telehealth use? And a lot of people say, well, so what? Does it actually make people's lives better? So getting to that point in our next work. And then there were a lot of themes around interventions and infrastructure. So thinking about infrastructure and support for patients and providers. What education do we need to make sure that providers can provide culturally relevant telehealth services? Addressing structural and systemic inequities, right? The trust issue kept coming up the whole 2 days. And as everyone said in the end of the day, the problem is that it's not even that people just don't trust telehealth. It's that all the populations that don't trust telehealth generally don't trust the healthcare system overall. So it's reflecting this larger issue of trust. And there's only so much we in telehealth can do to fix the whole thing, right? We're gonna work from our side, but it needs to still be a bigger process than just from the telehealth lens. You can see the rest of the themes here. So a lot of important themes that came up. Ultimately, when we voted on the questions, we had, in the end of the day, we had 8 voting patients and we had 52 voting attendees across the board. Patients are incorporated in both of these votes here. So all of the patient ones really showed up on thinking still on that barrier side and needing to understand the barriers and kind of address those better. So what facilitators and barriers to telehealth use are most important to address from the patient and family perspective? That was actually the #1 voted question across the whole group and for just the patients. The second one from the patient side was to the trust one. What are the patient and family trust-related facilitators and barriers to telehealth use? And then that third one, what are cultural facilitators and barriers to telehealth use? When we looked at the all attendees, and we've spent a fair bit of time talking about these findings with the steering group and the advisory board after, the kind of all attendees started getting at the outcomes more. These questions really kind of ranked a little lower. You can see on the side, so this #2, does facilitating telehealth use improve health outcomes among marginalized populations? This was number 12 in the patient rating, so interestingly, to us, very different. Our patients suggested actually that if we're looking at this and thinking about if it's improving the health outcomes, they still feel like we're putting the cart before the horse because we're so far from facilitating the telehealth use and we don't even understand the barriers well enough yet. So they felt like we were a little far down the line to be thinking about this in this setting yet. And then what are mechanisms by which telehealth improves patient outcomes? And that gets to that question that it's not just about do people use telehealth, but what is the ultimate so what we're getting to and making sure that we're thinking about that ultimate so what. So next steps from the conference are dissemination of findings, having conversations here, and other places, working with our local telehealth advisory board to think about what we can do in the Philly area next to be addressing these. And some of that work has been community initiatives I'll talk about. And then development of a digital health readiness screener. I already had this in my brain that I wanted to do this, and we were kind of trying to work towards that next. When all of these questions came up from the patients so soundly focused on, we need to understand and identify and kind of prioritize the barriers, it really made it clear that this had to be our next work. And so this will kind of expanding our concepts, right? So yes, we can decrease healthcare disparities only if we address the divide. Access to knowledge is not enough. Trust, and now I add in cultural competency as kind of the other primary one that came up from patients, are important underlying barriers to digital health use. So our digital health readiness screener work that we are doing right now is funded by the AHIMA Foundation. And this is a process that we are developing to hopefully routinely screen in healthcare encounters and identify for barriers across individuals. In my mind, it gives us an approach for efficient deployment of clinically integrated interventions to address identified barriers. And the example of that is going back to this kind of thinking about digital health readiness, right? If we had a screener that we could pull out, who are all of the people in our system who have problems with access? Then the next time I get $922,000 from the FCC, then we know exactly who to reach out to and give devices to, right? We can just pull them out of a record, and we can even prioritize to say, we want the patients who don't have access, who have 3 or more chronic medical conditions, or who have been in the emergency department 6 times this past year, or who we can start to look at their medical situation and their need around this. For the knowledge piece, when I, have version 2 of our digital onboarding task force, I have exactly who people should reach out to, especially we can prioritize. We can first say, let's find all of our patients who have a device and who are interested in using telehealth, but they're just like, I just don't know how to do that, right? If they have all the info, all they need is our, MPH student working with them for a couple hours, and we're gonna get them on a visit. For the trust piece, these ones get harder, right? But we've, in our institution, started to use a lot more community health works in places, and I've been working, as I'll talk about, in some work to train them as digital navigators. So we can start to look at having community health workers specifically, right? We'll pull out first the ones you have access, you know how to use it, you do video visits with your family, but you think it's kind of crazy to think about doing healthcare visits because that just seems not safe or not like something you do. And so then we'll have community health workers work with you to get over the trust barriers and to talk about some of those acceptability issues. And then for the relevance piece, maybe this is really clinician or peer education, right? This is flagging to clinicians who see their visits for all those in-person sessions to say, next time you have this patient, talk to them about the times that maybe telehealth could be a helpful addition, right? And I will flag here that I think part of the struggle, or a large struggle that we have with relevance with patients right now, is that most people are thinking of it still as an either or, right? They're thinking, I get healthcare in person or I get healthcare via telehealth. And few are acknowledging that like the optimal system and what we should all be striving for is a hybrid situation for everybody. What that will be, whether someone's 90% in person and another person's 90% telehealth, that will vary on everyone's unique situation, right? But I think people understanding that accepting it in is just a part of their healthcare and they're not giving up that in-person part is something that's missing for a lot of these patients who are still struggling on the relevance piece. And so we are well underway with this. What we've done for this process is we have engaged with extensive numbers of clinicians and patients to first just explore what is every reason that people are possibly not using telehealth, to make sure that we understand, this is called like exploration of the conceptual domain, but we understand that all the reasons that people aren't engaging in telehealth. And then it's been developing draft items for a screener that are trying to kind of capture that concept that people talked about. And so the initial screener, which is way longer than we intend in the end, but has had 29 questions. We have now been finished up kind of rounds of what we call cognitive interviews with patients. We go through each question, you ask them, they answer it, and then they talk to you about what that question means to them, how meaningful or not is it. And through this process, we're refining the screener to ultimately look at dropping some questions, refine the questions, make sure we're getting answers to exactly what we mean to be asking. And ultimately, the goal is to have like a super short screener that's getting at the main domains now that we're seeing what the domains are. And then as people come up with higher need, maybe a longer next set of questions that people can start to ask that we can train community health workers and others to be using. And so these are some of the examples of the current questions. And some of them are obvious, right? Most people would think, yeah, you should ask people, do you have access to a phone with a camera or a computer with a camera? Again, as we were talking about in the patient's environment, do you have access to the internet in a place where you're comfortable talking about your health needs? And then some of the trust ones that at least currently have been in the draft tool, are you concerned that you won't get high quality care on a telehealth video visit? And are you concerned about the privacy of your information when using technology for your healthcare? Because there are actually 2 components to that trust, as we found. There's trust in getting healthcare via telehealth, and there's trust in using their device for healthcare related needs because they don't want to have their personal information in their device. And those are both very important and real barriers, but kind of different factors. So where we're at with this, so we've got that we need to address the digital divide, access and literacy isn't enough, trust and cultural competency are important. I pose that a digital health readiness screener like the one we're developing can facilitate a systematic yet individualized process forward to address digital health equity, right? We can identify individual needs and then tailor our interventions. Now we'll talk about a few community initiatives that my team has been doing in Philly. So the first one that we are wrapping up on was in collaboration with, because really ultimately with all this, like we have to get in the community. It's that trust piece. We have to go to them and find them and be offering our help. And so that's what we've been working to do. So Esperanza Health Center is in Northeast Philly. It serves an almost entirely Hispanic population. And in talking with them early 2021, they'd really been struggling with the fact that they had thrown kind of all of the resources they could into getting their patients to use the patient portal, because they really found it a necessary way to be able to communicate with patients, to address their medication needs. They are very well embedded in the community and have a really close relationship with the population they serve, and they still were having immense barriers. And so my team worked with them and did kind of some initial research work in which we trained members of their community health worker pool to do research with us. So they got trained to do interviews, they got trained to analyze the interviews with us, and they went out in the community and talked to the community about what their needs were around getting the support kind of to possibly use things like the patient portal or ever think about video visits. And so we did that first initial round, and then we developed, based on what we found and the recommendations of those community members working on our team, developed kind of an onboarding toolkit. And what that ended up for them was a series of very brief informational videos that our community health workers made to stream in the patient waiting rooms and to use at other community events. And those were focused on things like what is the patient portal and how to request an appointment. And again, these are all, they're very short, they're very basic. They are made and narrated by one of the community members who's got even, the accent of the local community and everyone, and so have been very driven by the community. And so these were every single step of the way. And they found, so they've been using it in their health system at events since, that they have been able to show them and get multiple people on the spot to actually sign up for the portal and engage in those discussions. And so it's nothing rocket science in terms of what we've done for this, but it's taking the time and listening to and addressing the specific community needs has started to get them a step forward in this process. These are just some of their screenshots for what they developed in this video. And then more recently, this program has really just started and is my step forward in terms of thinking about how we can train people like community health workers and others who are associated with the healthcare system but not clinicians to actually address digital health needs. And so this project, called Advancing Digital Health Equity for Healthier Black and Latino Communities, is also in North Philly. The funding is provided by Johnson & Johnson, and this is being done at one of our community sites. So Jefferson, a few years ago, got funding to establish, in collaboration with Temple, a center called the Fraser Family Center and Coalition. This is a truly community-based center. No clinical care happens there, but is a center for people to come to get all sorts of prevention and education work, primarily focused on stroke prevention. The donor who gave the funds to establish this was really committed to stroke prevention among the Black populations in North Philly, where he had grown up. And so it's been kind of expanding out from there with a core focus on hypertension, diabetes, stroke, but really empowering health of the community. And so our goals with this work are to advance health equity among community members living in the high-risk zip codes in predominantly North Philly, where that is, and then South Philly, where we've got another similar community site, by improving digital health readiness and the use of digital tools. And so how we're doing this is that we are working with community health workers. These community health workers are getting trained to be digital navigators, and they will be using our digital health readiness tool that we've developed in practice in the community. They'll be screening everyone they can interact with at the community center, as well as different community events, to do an individualized digital health readiness assessment and then to intervene on what they identify. And some of these will be maybe one-stop shopping, and some of these will probably and hopefully be a long-term relationship as they really start to get past the barriers. But with this work over this year, we really hope to get to the point of starting to figure out how we can take this screener and what the types of interventions are that ultimately are needed for every single question on the screener, so that we can refine our CHW training and intervention approaches to really be maximally beneficial to the community. And then ultimately at the end of this year, we will be developing a digital health readiness curriculum to use at our enterprise. We've now got a community health worker academy, and so we will be training close to 15 community health workers every year, and for national dissemination other places to be adding to the pool, right? Lots of people are working on this in different places, but adding to the pool of how can we most efficiently be addressing needs. And so this is all also Philadelphia has a digital health equity plan, so we're making sure to align all this work closely with them and thinking about the core issues that they have of devices, connectivity, training in the workforce. How can we kind of train our community to address the needs, and thinking about the broader ecosystem. So ultimately, to our summary here, our last point is that I really do think, right, I've been in so many meetings where people say digital health equity, it's such a hard thing. What are we going to do about it, right? And I do think that an approach like a digital health readiness screener is actually a tangible approach to chipping away at this problem. And that ultimately doing this is going to involve a lot of work in the health systems, but it's also going to involve a ton of work of getting out into the communities and both working to kind of tease out the barriers that different communities have, but really to come to them and to start tackling those issues around trust. With that, I'm happy to take questions and comments of any sort. I also want to put it out there that PCORI work and that scoping review, we have like a lot of data we still need to tease into that, like, you name the population or the kind of specific barriers, and we can happily pull out all those articles and work on that. So if there's anyone out here who has some interest in that and wants to kind of be a mind to next steps with any of that work, please let me know.
Well, talk about contributions to the field. Amazing, amazing. Thank you so much. Let's give Dr. Rising a round of applause. Again, everyone's invited to submit questions here on the app, or you can come up to the microphones. And we already have a handful of questions. The first being, how are you staffing the outreach education components to build trust and readiness? For example, in-person home visits, credentials, caseload I'm not sure what that says, caseloads?
So that's been different at different times. For the work related to the FCC funding, and when we had kind of an official, pretty large, kind of 30-plus person digital onboarding task force, that was all virtual, which was really hard to do. And I think probably some of the calls took double as long as they needed to because it was all virtual. It was also being done in 2020 to 2021, and that was really our option at that time. I think as we move forward, we're focusing more on doing in person when we can. So community health workers out into community events, thinking about having community health workers or public health students or others, right? This is places that trainees always need their clinical experiences and their meaningful interactions with patients. And this is a perfect place for them to be able to actually to do some work when they don't need the clinical background to be addressing a lot of the needs. And so we've been looking at those alternative workforces like students and community health workers and such, and where we can put them both within our clinical settings, in waiting rooms, in places that they can get referrals, or business cards for a phone number that then they can be called and make appointments, but really trying to do more of the in-person with the rest of the people that exist at an academic medical center from our standpoint.
Thanks very much. Second question. When you refer to a digital health readiness screener, this is a process and instrument you describe. Who would use this?
Yeah. So our hope with this is that we can get to a short enough but meaningful set of initial core questions that this could be something that's added on when people are doing social determinants of health screeners. This has been something that increasingly there's been a lot of focus on over the past few years of the need to do this. The Jefferson Enterprise is over the next 3 months or so launching into within all the care settings, standardly social determinants of health screenings are happening. And I think that type of place and having it just be a standard part of the questions that are asked as intake is our goal with this. It just will have to be short enough, we're aware, to not kind of, everybody wants to screen for every type of condition, and so getting them in the right setting and getting them short enough to be regularly usable is a, core need.
Trust with our behavioral health clients is very challenging. Additionally, technology acumen and adaptation is an issue. Any suggestions? And thank you, excellent work.
Again, it depends, since trust is a broad kind of topic and word. I think we do find with a lot of patients that if we can get them on the initial visit and they can see and experience the range of what can happen on that visit, that a lot can be addressed in that. So I think there is a lot to, and sometimes or often I think this is having even someone be next to them. If they're at home and going to have this, sending someone to the home who they know, a community health worker, a person from the office, someone to actually set up the visit and kind of have that initial visit with them. But I think for a lot of people, getting them over that initial hump, however it may be for having initial visit, can be an important initial step for a lot.
Two more questions from online, and then we have some in-person questions coming up. Are you willing to share your 28 screener document?
My 28, yes. We are in a current active phase of refinement, but we are committed to and had confirmed with AHIMA when they funded that every step of the way this was going to be freely accessible, and like we welcome people using it, and we even more so welcome or like beg that you give feedback and maybe even some data back that we can be looking at and continuing to refine, but I'm happy to be sharing at every step. Yeah.
How do you plan to share out the digital health readiness screener to other organizations?
It's a great question. We were just having that last week for kind of what are our next, right? Because like our means of sharing academically, way too slow, right? So we will certainly be taking an academic lens, but we will also be figuring out probably initial places, and it may be that there will be emails and such via groups like MATRC and such, but that we will probably post it on my center's website and then have emails and such to distribute links and such to it is my thinking for the most immediate round of distribution. And yeah, we'll work via listservs, and certainly this community, I imagine, could hit on almost everyone interested in it.
Hey, thank you. Great talk. My name's Alfred Atanda, do peds orthopedic surgery, actually down at Nemours Children's Health in Wilmington, affiliated with Jefferson. We've been using, in our sports medicine clinic, utilizing athletic trainers as kind of this role of navigating patients. We use it more, I guess, clinically based, because the athletic trainers work with me. They know my workflow. They can counsel the patients before visits. They can counsel them and debrief with them after visits. I was just curious, for your particular model, are you utilizing that just to improve access and to help people kind of get into the healthcare ecosystem, or are you using it clinically for treatment and education as well?
Sorry, just to clarify, using the model of what specifically?
The digital navigators that you were talking about.
So the digital navigators are where in my spot, and I'm just like a part of telehealth and everything they're doing at Jefferson, we really have been focusing on that part of getting them on, of getting people who can't or don't want to or have whatever other barriers to using to empower them to use. Okay. Certainly, though, there are other team members and people from the clinical side working on ensuring that kind of continued use and that kind of barriers that come along the way and everything are addressed, and it's being used across our specialties clinically kind of regularly.
Okay, thank you.
Thanks so much for your presentation. I'm Lisa Davis, and I run the State Office of Rural Health for Pennsylvania, but we like Philadelphia too. And so I have two questions, and I'm just going to ask them both at the same time. So my first question is about trust. When you were looking at trust, were you at all able to differentiate between trust of patients who had already established a relationship with the provider who they were receiving telehealth services from? And was there any sort of correlation of trust regarding the type of service that was being provided? If they were just coming on because they were sick, or if there were issues like mental behavioral health, substance use, that sort of thing. So that's question one. Mm-hmm. Question two is entirely different, and it's about community health workers. So I'm so glad that you have focused on that type of community-based provider. And I'm wondering if, oh, look, my talk is so powerful, I put the lights out. Yeah. Okay, I guess my work here is done. But the second question then about CHWs is in terms of, there's all of this training now that's going on across the state through all of these organizations focused on CHWs. And I'm wondering if you are able to integrate digital training into that work that's being done. I was part of the group that developed the certification and training standards for CHWs. And at the time that we did this, no one was really thinking about this explosion of digital. So I don't know if there's a chance to work with the certification board on trying to refine some of the competencies for CHWs to include digital. So, sorry for long-winded questions.
That's fine. I'm taking the second one because it's in my brain. So yes, that is a great suggestion, I think ought to be the next step, right? So we're looking at the training in a module to incorporate into our CHW program at Jefferson. But certainly along with that, first of all, getting out the module is important, but I think looking at it becoming a core competency and not just an add-on that people can do is a really important part, because I think it just needs to be part of the social determinant screening that's happening already, is thinking about this just needs to be a core element of that. And so yes, thank you for that suggestion to kind of firmly plant that we should be looking at the competencies, and that is our intention, is to really get this firmly embedded into CHW trainings. Unless this year really shows us that there's some other challenge or barrier that it becomes too much for them, I don't think it will. I think it is one of the places that we should be routinely working on. The trust stuff, so those were great questions about trust. We have two top areas that we are starting to dive into all of the papers we had from the review, and trust is one of them because it's come up as the largest thing. And so we are not in those weeds enough to look at that at this point. I think some people have really raised that, right? Pre-existing relationship or not with a primary provider is probably not enough to find that. The question really is kind of their feeling of connection or adequacy, right? Like someone who feels like they have a strong connection with their doctor. If their doctor says, let's have this next visit by telehealth, they're probably going to do that. Also, you know, the people who don't have great trust in the healthcare system probably are much less likely to report that they have a really strong rapport with a doctor. So we'll try to pull those out as much as we can. Again, many of the articles that have looked at this, and I'm hoping there is some more granularity in some, but stayed so high level. I'm not sure how much depth we'll get, but we will certainly be looking into that. And you're welcome to help on that project if you like. Just.
Hi, I'm Melody Anderson, and I'm with the VA. I'm a telehealth coordinator with the Spinal Cord Injury and Disorders Program. And excellent presentation. I wasn't aware that you guys are out there doing that. In the VA, we kind of get in our VA world. And what you're working on is kind of in alignment what I'm looking at and what I've been seeing. I've been with our program since it started over about 12 years ago. And trust is huge with our population. And interesting to see how you have the community health workers out in the community, because that's a thought of mine. I have a project that I'm looking at e-health literacy of our patients. One of the things I just maybe wanted to comment on, and then also maybe just ask for a takeaway back for you and your team, the trust. I like how you have the brief sessions on these on-site. Has your project considered having where you have champions or folks in the specific facilities who are either in that program or in that service area where they're available during particular hours of a facility or a clinic, so that that patient or caregiver can go and receive training? And maybe the other one is, I was, in terms of the community health navigator, that's one of the things we're looking at, is we're calling it a little bit different, but I think it's the same thing. Looking at a designated technology navigator or manager, because with our patients who often have limited hand function, we're finding that the intergenerational hookup between our older patients, because many of them are older veterans or men, and to have them paired with someone in their family, we're having them to identify when they're first at rehab, who is the person who's going to help them to navigate, whether it's using the video, whether it's using the portals, or whether using other apps. So is that something that you consider in addition to pairing with that community health worker? Thank you.
Sure. I may miss some, so you may have to remind me. So in the clinical settings, I think sites and practices have tried to have someone available. It's just in most of the settings, resources are so strapped that they just don't feel like, I think most of the sites don't feel like they have that sufficient person. They often, I think most of them have the people who they know are better with issues. So like, oh, so-and-so's here. If you're having trouble, maybe, you know, she can pop in for a few minutes and try to figure out what's happening. But having a dedicated person, I think, is just really hard resource-wise right now. You had me, there was back to the trust one. What was your other one?
I know it was like so much I even forgot most of myself, but I do, just my experience, I'm finding that folks do have a tendency to be more open with the staff that they trust, as well as their caregivers or people who look like them. And we're also finding, maybe even establishing, since staffing is an issue, that peer relationship as far as trust, I guess, but maybe considering, for lack of time, that pairing that community health worker navigator with someone in their family as far as designating for their technology navigator, manager, however you want to call it.
Yeah. Absolutely, thank you.
So just another question from online that's been in waiting. Do you have a sustainability plan?
Personally, or not? More grants. I mean, I think in multiple areas, right? So sustainability of trying to address digital health readiness, right? There are the couple. So it's working on the screener, and then our next step will be working with our institution to get a few questions incorporated into EPIC and our social determinants of health screener, right? Starting to get that screening in as part of what we do every day. Doesn't need additional resources or anything. We have to resource screening people. So adding that into what we're doing. From the community health worker side, I think that is why we're focusing on them right now, because there is kind of, we're not adding new people, we're adding a new skill to what they're doing and what they need to be addressing in the community. And so I think things like getting into core competencies for community health workers is a perfect example of a sustainability plan, but incorporating this into the education that people are already getting instead of trying to just create de novo digital navigators, and that's all they do, right? That it's part of a menu of things that people can be helping with, I think is, you know, what we're hoping to be the sustainability plan for this.
Good morning, Shalandra Greenlee from North Carolina NC Council Coalition. I always have to share that first. At the beginning of your presentation, you mentioned in the continued discussion of trust in regards to the use of telehealth. In North Carolina, in the midst of the pandemic, and obviously when they finally allowed Medicaid to pay for some of those telehealth resources, some of the data that they were able to find after those services were rendered were that there was a high use of Black and brown individuals to use telehealth. But of course, looking just at BIPOC communities, that white individuals were more likely to use. But after surveys, it showed it was not just a trust issue, but also the fact that those individuals were not being offered the resource. Have you all done additional research, or have you all had the opportunity to look at those variations as well in regards to what individuals are actually offered as a resource, not just based on ethnicity breakdown, but often class and, you know, when it comes to their insurance?
So it's a great and important point that you make, and certainly I think, yes, there has been research of various sorts documented this, not a ton, but there's been some, and then I think it's been kind of experienced, you know, in different ways for all of us working these areas and conversations, that it is a concern. It was one of our discussion points at the conference as well, was thinking about the education of clinicians and getting over the just inherent barriers that people would have in their own minds of like, oh, my older patients won't use this, or so-and-so won't use this. It's another hope that with something like the screener and just identifying someone like digitally ready or digitally not ready, that it can be from a more standard place, and that we start to have conversations with providers about the fact that most people may have some barriers. Most of those we can address. Let's kind of talk to them and come from the point of what would you need to make this work. But it is a really important part from the provider education side that hopefully will start to dissipate with future generations of providers who are getting trained in the era of we're using telehealth, you know, as much as we can and across populations. But it is a real problem.
Thank you.
And that does bring us to time. So thank you again, Dr. Reisner.
Absolutely.